Welcome to the deep dive. Today, we're tackling a really intricate topic.
It's definitely complex.
Yeah, we're looking at treating advanced lung cancer when a patient also has idiopathic interstitial pneumonia, or IIP.
A very serious complication.
Exactly. And it's a huge challenge because, IIP itself can be fatal for these patients.
Oh.
And frustratingly, a lot of the standard cancer treatments can actually make the IIP worse.
A real double-edged sword.
Right. So our mission today is to really unpack a specific clinical study. It's the Hanshin Cancer Group IP001 paper. They were trying to find a chemotherapy option that's both effective and, crucially, safer for this particularly vulnerable group.
And it's worth stressing, despite knowing the risks of chemo in these patients for years, finding a truly standard, safe regimen, it's been elusive.
So a lot riding on studies like this one.
Absolutely. So this deep dive will get into what the researchers found, why it actually matters for doctors in the clinic, and, what questions are still out there for future treatments.
Okay, let's unpack this then. Why is this combination advanced lung cancer plus IIP? Why is it such a critical and, frankly, difficult problem?
Well, the paper really lays it out.
Yeah, it starts by saying advanced lung cancer, sadly, is incurable, high mortality. We know that.
Yeah.
But then you add IIP.
And the complexity just skyrockets. It really does.
The paper estimates the incidence lung cancer with IIP is somewhere between, 9.8% and maybe up to 38%?
That's a significant number, a huge chunk of patients facing this double threat.
Right. And what's really fascinating, or maybe terrifying, is the core dilemma you mentioned.
It is. IIP itself is a major problem, right? It scars the lungs over time, but then the things you do to treat the cancer surgery, radiation, even the anti-cancer drugs.
They can backfire.
Exactly. They can trigger what's called an acute exacerbation of the IIP, a sudden, severe worsening. It can be catastrophic.
So clinicians are walking this incredibly fine line.
An incredibly high-stakes balancing act, absolutely. They desperately need therapies that fight the cancer effectively, but don't cause devastating harm to already fragile lungs.
And that's the gap this study tried to fill.
Precisely. Addressing that critical unknown.
Okay, so faced with this tightrope, how did the study actually approach it? They focused on a specific type of lung cancer, squamous cell carcinoma. Why that type?
That's a really important strategic choice they made.
It seems specific.
It is. Squamous cell carcinoma is actually seen more often in lung cancer patients who also have IIP compared to, say, the general lung cancer population.
Ah, okay. So it's more relevant to this specific problem.
Exactly. Plus, treatments for other types of non-small cell lung cancer have really moved on. Lots of targeted therapies, immunotherapy. So doing a dedicated study just on squamous cell with IIP was, pretty crucial for guiding current practice.
And the study design.
It was what's called a prospective single-arm phase 2 trial.
Meaning everyone got the same treatment.
Correct. No comparison group within the study itself.
Yeah.
And it was conducted across 9 different hospitals in Japan.
Okay, so tell us about the patients. Who were they and what treatment did they actually receive?
Right. So they enrolled 36 patients between 2013 and 2018. 35 ended up getting the treatment.
And what were they like, demographics?
Well, the median age was 73. Pretty typical for lung cancer, ranging from 66 to 80.
Okay.
And overwhelmingly male, 31 out of the 35. And almost all were smokers, 34 out of 35.
That profile, male, older, smoker, that often aligns with IIP risk, right?
It does, yeah. Their IIP subtypes varied a bit. 11 had diagnosed IPF, idiopathic pulmonary fibrosis, which is the most common and, frankly, often the most severe type of IIP. 16 others were classified as unclassified IIP.
And the criteria to get in the study must have been strict.
Oh, very. They needed good functional status, basically, able to handle daily life, ECOG performance status 0 or 1, good organ function, obviously, and a confirmed IIP diagnosis.
Who couldn't participate?
Right, exclusions. Anyone whose IIP was caused by something else, like connective tissue disease. Anyone with a history of an acute IIP flare-up before the study. Or if they were already on certain strong immunosuppressant drugs for their IIP.
Makes sense. You want a relatively clear picture. And the chemotherapy itself, what was the specific recipe?
Okay, the regimen. It involved carboplatin, or CBDCA. The dose was calculated using AUC, area under the curve, of 5.
That's a way to ensure consistent dosing, right? Based on kidney function?
Exactly. To get a predictable drug exposure while trying to manage side effects, that was given on day 1 of the cycle.
Okay. And it was combined with?
Paclitaxel, or Paclitaxel. That was given at 70 milligrams per square meter.
70, okay.
Yep, 70 millimeter too. And that was given weekly days 1, 8, and 15.
And how long did this go on?
The whole cycle repeated every 4 weeks, and patients received between 4 and 6 cycles total.
Okay, so a pretty standard-sounding chemo backbone, but maybe the dosing or scheduling was key here.
Yeah.
So after all that, the big question, did it work? What did the data show about effectiveness?
Right. The primary goal, the main thing they were measuring, was the response rate. Did the tumors shrink? And it really delivered on that front. The observed response rate was 45.7%.
45.7%. How does that stack up against what they hoped for?
It comfortably beat their target. They'd set a benchmark of 40%, hoping to see at least that. So hitting nearly 46% was definitely a positive signal.
That's impressive, especially given how challenging these patients are.
It really is. It suggests this approach can be effective. To break it down, 16 patients had a partial response, significant tumor shrinkage, and another 15 had stable disease, meaning the cancer didn't grow.
Okay, so a good proportion saw benefit, or at least stabilization. What about survival numbers?
Yeah, they looked at that too. The median progression-free survival PFS, so how long patients lived before the cancer worsened, was 5.75 months.
5.75 months.
And the median overall survival OS, that's total survival time, was 9.99 months, almost 10 months.
Okay, those numbers give us a benchmark. But, I mean, the absolute critical question here, the elephant in the room, is the safety. Specifically, that risk of making the IIP flare up. What happened there?
You're absolutely right. That's the key concern. The rate of acute exacerbation of IOP during the treatment phase was 8.6%.
8.6%. How many patients is that?
That was 3 out of the 35 patients who received treatment.
3 patients. Now, obviously, any exacerbation is incredibly serious.
Life-threatening, yes.
But how did the researchers view that 8.6% rate?
They considered it an acceptable rate, given the high-risk nature of this patient group. It's a difficult calculation, but in context, it wasn't prohibitively high.
And crucially, what about overall lung health during treatment? Did lung function decline? Did breathing get worse?
That's another really important finding. They reported no significant decrease in lung function measured by FVC forced vital capacity.
So how much air they could blow out forcefully.
Exactly. And they also didn't see a worsening of dyspnea, shortness of breath, based on the MRC scale.
That's huge.
Yeah.
It suggests the chemo regimen itself wasn't actively damaging the lungs overall for most patients.
Yeah, it suggests it was generally tolerated from a respiratory standpoint, which is, frankly, a major win in this population.
Definitely. Okay, so lung safety looks relatively okay for most. What about other more typical chemotherapy side effects?
Right, there are others. They reported grade 3 or higher adverse events. These are the more serious ones needing medical attention.
They were the main ones.
The most common were blood count issues.
Yeah.
Neutropenia, low infection-fighting white cells, hit 34.3% of patients.
Wow, over a third. That's significant.
Very significant. Leukopenia, a general drop in white cells, was 25.7%. Anemia, low red blood cells, 22.9%.
Okay.
Also, hypertension, high blood pressure in 17.1%, and infections requiring treatment in 11.4%.
And febrile neutropenia. That's always a worry.
Yes, febrile neutropenia fever with those low white counts occurred in 2 patients, which is 5.7%. Still a serious event when it happens.
Those blood count numbers, especially neutropenia, are quite high.
Mm.
For patients who are already dealing with lung disease, how much does that add to the overall challenge?
That's a really sharp point. While the lung safety was the headline goal, these hematological toxicities are, well, they're not trivial.
Right.
Low white counts mean a high risk of serious infection. For someone already struggling with breathing or overall frailty, an infection requiring hospitalization is a major setback. It just adds another layer of complexity to managing their care. It's always a trade-off.
Let's circle back to those 3 patients who did have the acute exacerbations. Can we learn anything from their specific cases? Who were they?
Yeah, looking at those cases is important. All 3 were male, all smokers, ages 73, 80, and 75.
Okay, fitting that general profile we discussed.
Yes, and they'd had between 2 and 4 cycles of the chemo before the exacerbation hit.
And their IIP types.
2 of them were confirmed as IPF, that idiopathic pulmonary fibrosis. The third was unclassified.
And sadly, what was the outcome after the exacerbation?
Despite getting treatment like high-dose steroids and other supportive care, their survival after the event was very short. Progression-free survival ranged from just 3.6 to 3.9 months.
Wow. It really highlights how devastating that complication is when it occurs.
Absolutely. It underscores the severity.
So taking those cases and the broader data, What does this tell us about maybe predicting who's at higher risk for this terrible side effect?
Well, if you connect it to what we already know, the study discussion points this out. There are known risk factors for drug-induced lung problems, or pneumonitis.
Like what?
Things like older age, being a smoker, and having less healthy lung tissue visible on CT scans beforehand, like honeycombing or reduced lung volume.
And the patients in this study who had exacerbations fit that mold.
Pretty much, yeah. All three were male smokers. And the paper notes that their lung function before starting chemo was already showing signs of relative decline compared to others in the study.
I see.
So it reinforces those known risk factors. It really emphasizes you need to be extra cautious, monitor closely, especially in patients ticking those boxes. Careful patient selection is key.
Okay, so this specific regimen, carboplatin plus weekly paclitaxel, it seems to offer a reasonable balance, though not risk-free. How does it compare to other approaches people have tried for lung cancer with IIP?
That's a good question. Context is important. The paper does compare its findings. For instance, there was an earlier study by Minagishi, smaller, 18 patients, some with squamous cell.
Similar regimen?
Very similar, yeah. They actually reported a higher response rate, 61%, and their acute exacerbation rate was a bit lower, 5.6%.
Interesting. Higher response, lower risk? Why the difference?
Hard to say for sure with small numbers, maybe patient selection differences. Then there was another study, Fugivim. They used a higher paclitaxel dose, 100 mg/2 compared to the 70 in this study.
And their result?
Also a higher response rate, almost 70%, 69.7% actually.
Yeah. So does that suggest maybe the dose of paclitaxel matters quite a bit for how well it works?
It certainly hints at that, doesn't it? It suggests the paclitaxel dose might be a key factor driving the response rate, something worth exploring further, perhaps.
Definitely. Now, what about the newer treatments? Immunotherapy is such a big deal in lung cancer now. Are those checkpoint inhibitors an option for these patients with IIP?
Ah, yes, the million-dollar question. So regimens like platinum chemo plus pembrolizumab, they're standard for many advanced squamous lung cancers without IIP.
Right.
But for patients with pre-existing IIP, immune checkpoint inhibitors are generally considered, let's say, a relative contraindication. You have to be extremely cautious.
Why is that?
Because they carry a known risk of causing severe immune-related side effects, and the big one here is pneumonitis, inflammation of the lungs.
Which could be disastrous on top of IIP.
Exactly. There was a phase 2 trial testing atezolizumab, another checkpoint inhibitor, specifically in lung cancer patients with IIP. They had to stop it early.
Really? Why?
Because nearly a quarter of the patients, 23.5%, developed severe, grade 3 or higher, pneumonitis. It was just too risky.
Okay, so immunotherapy looks largely off the table for now. What about targeted therapies based on gene mutations?
Well, for squamous cell lung cancer specifically, the chances of finding one of those actionable mutations, like EGFR or ALK, it's generally quite low compared to adenocarcinoma.
Right.
So targeted therapy options are limited for most squamous cell patients anyway, and especially in this complex IIP setting.
So it really sounds like, despite all the advances, for this specific group, squamous cell lung cancer with IIP chemotherapy, like the regimen in this study, still holds a really important place.
I think that's a fair conclusion, and it's what the study authors suggest too. They point out that this carboplatin paclitaxel regimen is still frequently used for IIP patients in Japan.
They even called it potentially the optimal regimen available at this time.
They did suggest that, yes, in clinical practice, given the limitations and risks of the alternatives, this chemo combination might represent the best available balance right now.
Okay, one more angle. What about drugs specifically for the IIP itself? These antifibrotic agents like pirfenidone or nintedanib. Can you add those to the chemo to maybe protect the lungs?
That's a logical thought, trying to treat both problems at once. People have looked into it.
Yeah,
The results have been, well, mixed. There was one small study suggesting pirfenidone could be safely combined with platinum chemo.
Okay, promising.
Maybe. But then a much larger trial, the JSONIC study, added nintedanib to chemo. They hoped it would improve survival or reduce those acute exacerbations.
Did it work?
Unfortunately, no. It didn't show a significant benefit on either of those fronts, especially in the squamous cell patients.
Huh. So that combined approach, while appealing, hasn't clearly panned out yet.
Not consistently, no. The evidence isn't strong enough yet to make it standard practice.
Okay, like any study, this one isn't perfect. We need to look at the limitations. What did the researchers themselves point out as caveats?
They were quite upfront about them, which is good scientific practice.
So what were the main ones?
Well, first, as we mentioned, it's a single-arm study. No direct comparison group getting a different treatment or placebo. That always limits how strong your conclusions can be.
Right, you can't definitively say it's better than something else based only on this.
Exactly. Also, the number of patients, 35, was slightly less than their original target of 40. That could affect the statistical reliability, make the results slightly less robust.
Okay, what else?
The specific type of IIP wasn't always confirmed with a lung biopsy, which is the gold standard. They often relied on imaging patterns, which can sometimes be ambiguous.
It's a little bit of variability in the patient group, maybe.
Potentially, yes. And comparing lung function over time was tricky because they actually revised the study protocol partway through its long duration.
Okay, so comparing apples to apples became harder.
A bit, yeah. And finally, they noted that during the study's enrollment period, which spanned several years, those antifibrotic drugs, pirfenidone and nintedanib, became more widely available and used in general practice. But the study didn't systematically track or account for their use. So whether those drugs influence the outcomes for some patients, well, we just don't know from this data.
Okay, those are important points to keep in mind when interpreting the results. So let's try to wrap this up. What does this all mean for you, the listener? This deep dive, it's really shown just how complicated treating advanced squamous lung cancer is when IIP is in the picture.
It really has. And I think this study, the IP001 paper, it gives us a valuable piece of the puzzle. It shows that this specific chemo regimen, carboplatin plus weekly paclitaxel, it can offer a reasonable balance.
Effective enough with manageable, though not zero risk.
Right. The response rate was decent, comparable even to patients without IIP, which is quite something. But connecting this to the bigger picture, it absolutely highlights the need for more research.
What kind of research specifically?
We desperately need ways to better identify those patients at highest risk for the acute exacerbations, finding more specific risk factors, maybe biomarkers.
So we can personalize treatment more, be even more cautious with some.
Exactly. Move towards more precise, individualized strategies. That's the key to making treatment even safer in the future for this incredibly challenging group.
It really does make you appreciate the meticulous work researchers do trying to find answers in these complex situations. As we finish thinking about the process of this kind of research, what's one challenge, maybe like that long study duration you mentioned, or getting enough specific patients that you think is often underestimated but really crucial for progress here?